Hello, can you hear me? Can you hear me?
Yes, doctor.
Okay, right. So we will start with our first case. This is a 50-year-old male patient who was referred to hematology because of the progressive anemia and tiredness. The full blood count was done and it shows HP of 98, normal white cell count, and slightly low platelet. This is the power 10. Yes. So this is the power 10 overview. And now let's go to power 50. Right. So you have seen enough section. You are asked to report this blood film. How would you report this blood film?
Yes.
Yes, go on.
The peripheral blood film show anisopakilocytosis with polychromasia, uh, schizocytes, and Howell Joly bodies, and some target cells.
And these cells,
teardrop cells.
right. So this is not the complete report. You have to complete your report.
Platelets looks adequate, and white blood cells also looks normal and adequate in number. No increase, no increase in white blood cells.
These things,
Howell Joly bodies, I
yeah.
already mentioned,
Okay. So still your
and
report is
hypochromic cells are evident. Hypochromasia.
still your report is not complete. You need to give your impression.
I see
What it
some.
can be. So there is a lot of tear dropping that you have noticed. There are whole Joly bodies. There were few target cells. Uh, there were there is hypochromia as well. White cell has no abnormality. There are rare polychromatic cells as well. Platelet and isocytosis because few platelets are small, few are large. Patient is anemic. What do you think can be the likely possibility here? So this patient has Howell Joly bodies. What does it signify?
Hypersplenism.
Hyper or hypo?
Hypersplenism, sorry.
Patient is 56-year-old. He has developed hyposplenism and he has anemia as well. So what will be your differentials in your mind if someone has hyposplenism and anemia at the age of 50? So let's say I tell you this patient has abdominal discomfort because of the uh, splenomegaly. Now this patient has anemia, splenomegaly, and this is the blood film in front of you.
The
The
feature
general,
of teardrops, we will suspect myelofibrosis.
okay. So in general, for the exam purpose and also for real life as well, if someone asks you that this patient is progressively anemic and he has splenomegaly as well, so I would think about two differential on the top. Either this patient has myelofibrosis or he has hairy cell leukemia. I need a blood film for this to see what is the picture over there. If he has hair tear drops, so likely myelofibrosis. I cannot diagnose myelofibrosis on blood film. It has a specific criteria. Um, and if there are hairy cells, yes, likely it is hairy cell leukemia. Still, I have to confirm it on bone marrow biopsy and hairy cell leukemia immunophenotype panel. Yeah. So you think that this is uh, myelofibrosis. This patient has done bone marrow biopsy because everyone was thinking that this may be uh, myelofibrosis. So let's see what does the refine says then. This is power 4 for the Trifine. Hope it is clear to you. This is H&E stain. Um, Although we use a lot of stains in our HMDS diagnostic services, but for the exam it is H&E that will appear. Giemsa stain will only come for systemic mastocytosis because mast cells like Giemsa stain. Do you have any comment on this power 4? So length of trifine is fine. Trabecular spaces are okay as well. The trabeculae are a bit distorted. They are fragmented and thickened as well. And you can see these linings here. This one, and one line. The feature of fibrosis in this patient. Here as well. These megas are small. They are not small because they are a feature of myelofibrosis. They are small because they are squeezed between the fibers. Small mega is a feature of CML and MDS5Q only. Rest of the conditions has normal mega. So still, if you cannot pick it up on this one, they will give you retic. So this is your retic, and I will make it forward 10. And you can see these fibers intermingling. So this is either grade 3 or grade 4 fibrosis in the patient. Make it more big to you. This is, you can see, is all fibers intermingling. These are all intermingling. So this patient has um, myelofibrosis, is grade 3. This patient has megakaryocyte atypia as well. You have noticed small mega in this one because they were contracted by the um, nearby fiber. And you have to exclude BCR-ABL1 according to the WHO 2022 criteria. And then you should have minor criteria as well: high LDH, leukoerythroblastic picture, splenomegaly, white cell count high as well. then it will make a diagnosis of myelofibrosis. So when you report the blood film for the FRC path exam purpose, you need to comment on the cell line, um, starting from the one which has the abnormality, and then you have to give your impression, like whether this a what are you suspecting in this patient, and then you have to give your opinion as well, suggestion, what next you would like to do in this patient. This patient has a lot of red cell features which you have mentioned, and the platelet endocytosis, white cell count was normal, white cell morphology was normal. Impression is likely of myelofibrosis. We would like to do a bone marrow biopsy in this patient and BCR-ABL1 to, uh, to exclude the diagnosis of myelofibrosis or other myeloproliferative disease. Then your report will be complete for the exam purpose. Obviously, you belong to different countries. There is different reporting system. But for UK, they gave first comment on the cells, then your impression, and then your suggestion. Because most of the blood films they will be sent to you by the GP, and not they are not in the hospital. So you will comment on the blood film, and they will expect you what we are thinking and what they should do next. The next case is a 19-year-old female who, who was referred to us because of progressive anemia and tiredness. This is power 10. Let's put the 10 time. Okay. So let's see this film on power 10 first. So hemoglobin in this patient is 110, white cell count is 22, and platelet count is 130. And obviously, it is visible from power 10. But
Microcytosis.
yeah, there is some problem with cell in this patient. So let's go to power 50 and see what is it. So your lab your lab colleague have seen the blood film and he thinks that this is CLL. But the other colleague in the lab have seen this blood film and he thinks that the patient is young, 19-year-old. So these are reactive lymphocytes. Now they have sent the blood film to you for your reporting and comment. So let's see a few slides here and then you can comment on the blood film. What do you think?
Definitely, this is not CLL, nor it is a reactive lymphocyte.
You have to then report the blood film
Yeah,
and teach your lab colleague that what are you thinking about this blood film.
Good afternoon. Anyone, did you hear me?
Yes, we can hear you.
I noticed that there is mild anisocytosis. There is leukocytosis, mainly lymphocytosis with a little bit small lymphocyte with fine chromatin, high NC ratio, and marked thrombocytopenia.
Okay. So what is your impression?
My impression may be acute leukemia for immunophenotyping to confirm the diagnosis.
Okay, so you would like to send referral blood for immunophenotyping in this case.
Different blood for immunophenotyping.
Okay, so CD19 is positive, CD10 is positive, 20 is positive, CD4 is negative, CD5 is negative, CD7 is negative,
Okay.
TD3 is positive as well.
What about surface immunoglobulin?
The surface immunoglobulin is negative, but
If
weak.
it's
I should say weak. It is weak.
CD79A, what about it?
CD79 is negative.
I'm not sure, but maybe acute leukemia, according to morphology, maybe L1.
We do not use the FAB classification anymore. Okay. So first of all, tell us about these cells. What makes you think that this is acute leukemia and it is not CLL or infectious
lymphoma.
mononuclear? Be quick, guys. I have to go somewhere.
My NC ratio is relatively open chromatin, and there is some nucleoli as well. And they are monomorphic. They are not polymorphic like the IM1s, very scanty cytoplasm.
Yeah. There is obvious nucleoli.
Nucleoli.
Make it power 100 if I can. So this is the nucleoli present in this cell, and this one as well. This has a lot of nucleoli, and this one has many as well. Cytoplasm is very scanty. So on the peripheral blood, we can only say that this is leukemia or not. Okay. This patient has leukocytosis. Abnormality is in the white cell, so comment on the white cell first. Then go to red cell and platelet. Give your impression that this is likely acute leukemia, and give your suggestion that we need urgent peripheral blood flow cytometry for this patient. When I mentioned to you the TDT is a marker of immaturity. It means this is acute leukemia. But on peripheral blood, you cannot say whether this is acute myeloid leukemia or acute lymphoblastic leukemia. You need a peripheral blood flow for that, because things usually are deceiving on the peripheral blood film morphology on. You may be thinking acute myeloid leukemia and it comes out as ALL. You may be thinking ALL, it comes out as AML. So we always trust on the flow cytometry and such. Okay. So can you tell me any standard risk cytogenetic or and one poor risk cytogenetic in ALL? Yes, go on. Standard risk cytogenetic and poor risk cytogenetic.
So
Poor
high risk patients, the age, and
No,
the high
I'm asking about cytogenetic. Tell me
cytogenetics.
one
Yeah,
standard risk cytogenetic and one poor risk cytogenetic.
right. So the standard, basically not high risk. The high risk is Philadelphia, BCR, ABL1,
Mm-hmm.
and T119,
Mm-hmm.
and MLL
What about the
114.
standard risk cytogenetics?
Um, I'm not sure. I think hyper diploidy, but I'm not sure about the others. Sorry.
Yes, hyperdiploidy is a
Yeah.
correct one. Hyperdiploidy carries standard risk cytogenetics everywhere, and hypodiploidy carries poor risk cytogenetics. 1221 translocation is a standard risk translocation
Okay.
in the ALS.
Yeah.
All right.
Okay.
So this is another case, third case, and this is a again 19-year-old boy with anemia. Yeah. He is an immigrant from somewhere to UK, and the GP referred this patient to you because the patient had abdominal discomfort and low hemoglobin as well. The parents told you that he was diagnosed as a sickle cell patient back in the country. So This is the poverty. And let's go to power 50 for more detail.
Can I comment?
Go on.
RBCs show anisopoikilocytosis, including target cells, sickle cells, polycythemia, Howell Joly bodies. There are some microcytic hypochromic cells also. I didn't recognize the white BC's morphology. Can you move? The patient presented with what?
Anemia.
Oh, so till now the white BC. I think what are these? Lymphoblasts or what? No,
These are
activated lymphocytes. Can you move again for more fields? Activated reactive lymphocytes. Platelets are how much?
platelets are 130. Sorry, 160. If you can comment on the void cell, that is fine. If not, it is not an issue.
Yeah, I think activated and reactive lymphocytes.
This patient has a dual diagnosis. So I brought it only for the purpose of hemoglobinopathy.
Sickle cell. Yes.
Hmm.
But sickle was target. It means something. SC hemoglobin maybe.
Okay, so you want HPLC from me. So um, the sickle cell is 78%. A2 is 7%. A0 is 5%.
Sickle beta.
Okay.
A2
It
is
is
what? How A2?
7%.
Sickle beta.
So can you tell your colleagues why you are thinking this is sickle beta and not homozygous sickle?
Because beta thalassemia comes with a high A2 level, and it comes with the target cell. Thalassemia red cell investigation
Because unpaired,
means high.
So in presence of sickle cell, A2 does not carry any value. It is the A naught that you have to consider. So sickle cell, because sickle cell is 78%, and there is some A in this patient as well. So, and you would have F percentage in this patient as well. If it was only sickle, you would see all the sickle cells here. Because there is hypochromia, target cells feature, MCV in this patient would be very low. So, and there is some hemoglobin, some beta chain activity is present. So this is sickle beta. Hemoglobin above 5 or above 5 means beta plus. If the hemoglobin was 2%, A naught was 2% or 3%, I would have called it as sickle beta naught.
Sorry, can you repeat that again, Dr. Ahmed? So because this
Okay.
patient A
If this patient has all the sickle cells on the blood film, and the HPLC says that sickle percentage is 90%. Sickle hemoglobin is 90%, so this is homozygous sickle cell. If in this patient, the sickle hemoglobin percentage is 78%, there is some F in this patient as well, and hemoglobin A naught is 5%. It means there are some beta chain activity present in this patient. He is not completely homozygous sickle. Because of beta chain activity, you are seeing microcytosis in this patient, some target cells in this patient, hypochromia, because the activity is very less, but still there. So when you report on the HPLC, you look at the abnormal hemoglobin, which is sickle cell here. What is A2? What is A naught? What is the F percentage? To compensate for high sickle cell hemoglobin, this patient would have some F percentage as well. So if it is all sickle hemoglobin, it becomes homozygous sickle cell. If it is 70 to 80% hemoglobin, sickle hemoglobin, and you have some A naught is our hemoglobin, the adult hemoglobin. It means there is some beta chain activity is present. It becomes sickle beta. Then you quantify you quantify A naught level. If it is above 5% or below 5%. If it is above 5%, it is sickle beta plus. If it is below 5%, it is sickle beta naught. Is it making sense or not?
Yeah.
Okay. So A2 does not carry value in presence of sickle cell. It is A naught, the adult hemoglobin, which carries value. If you don't have A naught and it's only sickle hemoglobin, then it is homozygous sickle. If you have some A naught, then you need to quantify it, how much A naught is there, above 5% or below 5%. Above 5%, sickle beta plus. Below 5%, sickle beta naught. And I mentioned this patient has dual diagnosis. These are two big Howell Joly, this one. And I mentioned this patient has dual diagnosis. That's why I was not commenting on the white cell. Usually such films does not come in the exam with a dual diagnosis. This patient has ALL plus sickle beta thalassemia. And regarding the reactive lymphocytes usually has scalloping. These cells don't have scalloping. They are blast. Some of the white cell has nucleoli, and they have minimal cytoplasm. So only I commented on the red cell pathology, not on the white cell, because dual pathologies usually does not come in the exam. You may have seen your patients who may have multiple myeloma plus CLL phenotype as well, who may have biphenotypic leukemia, who may have CML and CLL phenotype at the same time, but in the exam, they does not appear. If it was a reactive lymphocyte, they would have a lot of cytoplasm, and it would have scalloped these cells and these cells. I had shown you the infectious mononucleosis cells before. It enveloped the cells, and they are quite large cells. These are small cells. They have minimal cytoplasm. They are leukemic cells. But I was not touching these cells because it is a dual diagnosis. So dual diagnosis makes you confused in the exam. That's why it does not appear in. This is again a 19-year-old young patient who had a motorcycle accident uh, 3 years ago and has abdominal surgery. So this film is not for diagnostic purpose. This film is just for the features. What features do you see in this blood film? Abnormal features do you see in this blood film? This is power 10. And regarding HPLC is a FRC part 2 question. It will not appear in part 1. You will have HPLC graph with you. You can quantify the hemoglobins very easily. Now let's go to power 50. So what abnormality do you see in this blood film? And does it correlate with the patient abdominal surgery or not?
So red blood cells and isopoikilocytosis with the marked target cells, spherocytes, and we could see whole Joly bodies, which does correlate with possible splenectomy.
What are other features of splenectomy? You mentioned Howell Joly body, target cell. Is there any other feature of splenectomy? The reactive thrombocytosis is a feature of splenectomy. So when you go through the ET guideline and you open the table in the BSS guidelines for essential thrombocythemia, they tell you one of the reactive cause of thrombocytosis is splenectomy. Some of the blood films in the Part 2 exam will be for listing the features in the blood film. They will ask you list 6 features in this blood film. So you will write target cell, Howell Joly body, 1 RBC. In RBC we have seen if there is spherocyte with the mineral spherocyte, we have seen macrocyte here as well, thrombocytosis. So all the blood films in the exam are not for reporting purpose, are not for diagnostic purpose. They may ask you what is the differential diagnosis of blood film. Okay. So this blood film is post-splenectomy. People think that this may be hemoglobinopathy because of a lot of target cell. No, this is not a hemoglobinopathy because previously he was well, no family history of any hemoglobinopathy. Abdominal surgery. This patient has history of abdominal surgery because of splenic laceration and splenectomy. That's why we are seeing a lot of Howell Joly bodies in this blood film, thrombocytosis, um, target cells. So the next question can be, what prophylaxis? Would you suggest any prophylaxis for this patient or not?
Vaccination. Pneumococcal vaccination and Haemophilus influenzae vaccine.
Plus meningococcal, yes.
You can say in broad term, encapsulated bacteria organism. I think there was a recent update regarding the Haemophilus influenza. They have removed Haemophilus influenza from the regular vaccination. It's only meningococcal and pneumococcal vaccination. Check that in the guidelines. And what else?
They need penicillin also.
Sorry?
Penicillin and folic acid.
Penicillin and folic acid as well. Right. Because of splenectomy, they are at risk of 2 major things. One is infection, and what is another risk factor in a patient with splenectomy?
I think maybe thrombosis. Sorry, thrombocytosis.
Your first point was correct. We are at risk of thrombosis, especially which vein thrombosis?
Deep vein thrombosis.
All the veins are deep inside our body, but there is a specific vein which is more prone to have thrombosis post-splenectomy, and it is usually a part 1 MCQ question as well.
Hepatic vein thrombosis.
Portal vein thrombosis.
Portal vein. Sorry,
Common in
I'm working in the lab for many years. I forgot many information. Sorry.
So they appear as a FRST part on MCQ. They ask you which vein thrombosis is common post splenectomy. And we usually do not give them prophylactic thrombophylaxis. Like thrombophylaxis, we do not give these patients. But if they have any other risk factors, for example, they are obese or they have any cancer with as well or having any active chemotherapy, and we think that they are at risk of having clot, then we give them thrombophylaxis. So it is always case by case situation. Routinely, we do not give anticoagulation. This is the last case that was posted in the group as well.
Sorry, Amir, may I ask for the previous film?
Yes.
Yeah, just with the target cells, because we're really significant, is that actually one of the main features of splenectomy, increase the target cells?
Yeah, so target cells can appear in many conditions, like in hemoglobinopathies, liver disease, and splenectomy as well. So this patient liver was normal. He had no previous history of any hemoglobinopathy.
Yeah.
He had splenectomy on. So in UK, you keep the record of everything. Okay. If
Okay.
you go to your hospital and ask for your blood test from 2001, they will have the blood test record and blood films as well. So this patient had no previous such findings on the peripheral blood film. They appear post. So liver target cells can appear in liver disease, in hemoglobinopathies,
Yeah.
in splenectomy.
Sure. Okay.
The patient has no spleen at all. Yes, he developed a target cells thrombocytosis and Howell Joly.
Right. Okay. Yeah. Thank you.
This is the last case. This is a 5-year-old boy with jaundice. This is power 10.
Sorry, did you say with jaundice?
Jaundice, yeah. This is power 50. You will see this film in your exam if you are going for part 2. Because this is from. This is not red cell pizza. Someone mentioned that this is a red cell pizza. This is not red cell pizza. So what are the findings in this blood film?
Yeah, there is a red cell anisopocytosis with it's kind of mixed population really. There are spherocytes, microspherocytes, polychromatia, and many hypochromic cells as well. There are many elliptocytes-like cells, and occasional teardrops like cells.
Okay.
Yeah, features are going with likely hemolysis.
Yes, hemolytic anemia. But what
Yeah.
type of hemolytic anemia?
Right. So I would like to do further investigation to exclude intravascular hemolysis like cold hemoglobinuria or
Cold hemoglobinuria?
sorry, PCH, paroxysmal cold hemoglobin.
If it was cold, there should be some red cell agglutination.
Right, yeah, you are right.
First step in hemolysis is always a DAT test to find out whether it is immune or non-immune.
Yeah.
Yeah. So DAT test is negative here.
This is erythropoietic
Okay.
anemia.
So like a non-immune then.
It's a non-immune anemia. So what do you think?
This erythropoietic. This erythropoietic features looks like that.
Congenital dyserythropoietic anemia, CDA.
Yes, yes.
Usually we diagnose that on the aspirate, not on the peripheral blood film. And congenital dyserythropoietic anemia have other systemic features as well, and peripheral blood film is not that severe. This blood film has macrocytes, hypochromia, spherocytes, fragments even, different sizes of
Pyropokilocytosis. Pyropokilocytosis.
Maybe
Pyro-
membrane. So
sorry, what did you say?
maybe membrane, RBC's membrane defect.
Yes, RBC membrane defects are more than 5, as far as I know. Which RBC membrane defect? Stomatocytosis?
Okay.
Ovalocytosis. Or
Sorry?
there is spherocyte. Also
Okay.
there is ovalocyte.
This is spherocytosis or ovalocytosis?
The ovalocyte is more prominent.
Yeah, ovocytes are prominent here.
Okay. But somebody says this is elliptocytosis.
Maybe.
This is elliptocytosis, ovalocytosis, or stomatocytosis. What is this?
It is not stomatocytosis.
Okay.
I think it's elliptocytosis.
You say this is elliptocytosis, but what about these spherocytes? Think about these spherocytes. There are so many.
Maybe transfuse.
Transfused, if they were transfused, there should be a lot of cells like this one.
Yeah.
But there are only few cells like it. Transfused cells should not have this much of spherocytes. This slide is full of bunties.
Pyrocytosis.
And then what about these electrocytes? This is pyropokilocytosis. you can see wide range of aniso and poikilocytosis in this blood film. This film has macrocytes, elliptocytes, spherocytes, fragments, teardrop cells, Howell Joly bodies, contracted cells, everything. Medical terminology, the lab terminology is vomitus of red cell or red cell vomitus. So this is hereditary pyropokilocytosis. If it was spherocytosis, then you should have only spherocytes. If it is elliptocytosis, then you should have only elliptocytes. I think I had showed you the elliptocyte before, which is full of elliptocytes like this. They don't have macrocytes or spherocytes or teardrop cells, that thing like that. Is it autosomal recessive or dominant?
Recessive?
This one is recessive, I think, and it is usually a mild disorder, does not need frequent transfusion, just observation and folic acid in the patient, and nothing else. Okay, so that was it for today, and enjoy the Sunday. Do you have any questions?
Thank you, doctor.
If you are
Thank
if you are
you.
preparing for part 2 exam, I say part 2 exam, then I would advise to join regularly, and not join regularly, participate as well. If you can participate here, you will be good in exam, because most of the people fail the day 1 of FRC part 2 exam, because people are having anxiety for the exam. They are going for the first time. The timing is the issue. 9 minutes for one blood film. It's not that they don't know, but because of the timing issue, they usually fail the questions and fail the exam. So do not hesitate. Nobody knows you. Okay. If you are afraid that your friend will know you that this man does not know anything, change your name on the screen. But I would encourage you to participate. It's for your benefit. I'm done with my exam. I'm doing these sessions only for my interest.
Thank you, doctor.
Okay. So take care and have a nice Sunday, and see you next Sunday then.
Thank you very much.